It's a pleasure to be with you all today. And yeah, I'm going to be talking about symptoms of depression and anxiety associated with dementia. These are my disclosures, some grant support, honoraria. And as usual, we like to note that uh, the main support for this series came from the Public Health Agency of Canada to the Canadian Coalition for Seniors Mental Health. And that we do our best to be evidence-based. We often don't have as much evidence as we'd like, but we do our very best to be evidence-based. And we hope that there'll be no significant bias. And we'll be asking you later on about that. So for today, the learning objectives. So I'm hoping that by the end, you'll be aware of the high prevalence of both depression and anxiety associated with dementia, be able to list useful screening and diagnostic tools, and be able to outline the range of treatment options or interventions for both depression and anxiety associated with dementia. So the impetus for this whole series originated with funding from the Public Health Agency of Canada, and some of that funding went towards the creation of these guidelines that you see here. And the guidelines covered 5 particular areas of focus of BPSD, as you can see listed here, and 2 of those are indeed depression and anxiety. So I will be along the way mentioning the actual recommendations from this set of guidelines, which are very evidence-based. This is a nod to all of the amazing people who put together these guidelines. And as you can see, it's a huge range of experts, working group members, people with lived experience, trainees, project staff, and expert reviewers. And you heard from Dr. Jennifer Watt last session, and then Dr. Dallas Seitz is the other co-chair for these. He's on board during this session today. Dr. Watt showed this particular slide last time, and I just think it's very, very important as we think about BPSD that there are just so many factors that contribute to the development of behavioral or psychological changes associated with dementia. And I think this slide neatly covers that, noting that indeed there are biological changes related to neurodegeneration. There are many different factors relating to both the patient, caregivers, and the environment that all interplay with each other that all lead to increased vulnerability to stressors and ultimately can lead to these various symptoms. But it is complicated. And as we think about it, we need to always take a holistic approach and a biopsychosocial approach. I've got a few quick poll questions for you. And so if you can answer these, that would be really great. First one relates to prevalence of these particular symptoms. So which are most common, depression, anxiety, or they about the same? Perhaps we could look at the results so far. Okay, got some answers in all sections, but the majority are saying that they're about equal in frequency. Excellent, thank you. Then the next question. Yeah, so do the behavioral and psychological symptoms all become more prevalent as the severity of the dementia increases? Is that true or false? That's great. Maybe we could get the results. Oh, about equal. Thank you. That's great. That's what I like to see. Great. Thank you. And then one more question. It's about antidepressant medications and how effective they are in this patient population. So, so antidepressants are better than placebos. people with depression associated with dementia. Is that true or false? That's great. Perhaps you could have a look at the results there. Okay. So the majority say that yes, they're better than placebos. We'll answer these questions as we go along. This is a bit of a complicated slide, but it's actually from a very important meta-analysis. So this looked at over 5,000 people, many different studies looking at the prevalence of anxiety, depression, and apathy. And those arrows a bit miscued there. But if you actually look at depression for all forms of dementia, you'll see a prevalence rate of 39%. This is depressive symptoms, not actual diagnosis of depression. And then for anxiety symptoms, really interesting. In this particular meta-analysis, um, 39% as well. So kind of a tie there. So there's the answer to one of those questions. And apathy is actually more prevalent at 54%. The this meta-analysis also broke down Alzheimer's disease from vascular dementia. And in this particular uh, analysis, it seems as though the symptoms for vascular dementia are somewhat more common than with Alzheimer's dementia. And then if you look at stages of dementia, not that much difference actually across different stages, but it looks like the middle stages overall seem to have the highest rates. And this is from a study over 20 years ago. The slide is often shown, but it actually shows that for some of the symptom groupings, the prevalence actually declines as the severity increases. So for hallucinations, anxiety, and disinhibition, the prevalence actually declines as you go into the more severe stages. For the other symptom groups, it increases. This is also an old slide from McShane, who grouped the clusters of symptoms into 5 groupings. So and they are aggression, agitation, psychosis, apathy, and depression. And I think the main point here is that there's a real overlap between a lot of these, and some more so than others. So naturally, for example, apathy and depression overlap a lot. And there's a fair amount of overlap between the other 3. So, but really, they all can overlap with each other. And so while we, try to talk about an individual grouping or cluster or particular symptom, it's always worth remembering that these symptoms are often coexisting, overlapping, which makes it challenging both to write guidelines, but it is also challenging to care for these individuals, of course. But we like to simplify things and to create simple categories, but that's not always reality. So let's talk about depression in people with dementia. So first of all, depression is a risk factor for dementia. So there's been many studies looking at this. So what's consistently shown is that early life depression is associated with a very significant increased risk of dementia later in life, about a twofold or greater increase. When you look at studies of late onset depression, it's more inconsistent, but the majority do support an association, but that could be a complex reason for that, including the fact that depression may be a prodrome for the development of dementia, an early symptom, if you like. There are likely many biological mechanisms linking depression to dementia, as listed here. They include vascular disease, changes in glucocorticoid steroids, hippocampal atrophy, increased deposition of beta amyloid plaques, inflammatory changes, and deficits of nerve growth factors like BDNF. So that's important to remember. Very importantly, there was a prospective study from the UK, which discovered that participants who had untreated depression had a 30% higher risk of developing dementia than participants who received appropriate treatment. So this would suggest that it's certainly important that we recognize and treat depression earlier in life. This comes from a recent paper by Huang, and it looks at the whole association between dementia and depression and the different mechanisms as listed here. So it includes causative mechanisms, bidirectional mechanisms, shared mechanisms, mechanisms or comorbidities that occur just by chance, and genetic factors. So it is complicated, but one thing that's clear is it's bidirectional. So in other words, if you're depressed, that can contribute to the development of dementia, in this case, Alzheimer's, and of course, vice versa. Studies suggest that depression in dementia is associated with poorer cognition, greater caregiver burden, poorer physical function, greater mortality, more likely admission to long-term care, and poorer quality of life. So this is important for us to recognize and, if possible, to treat. So this comes from the guidelines I mentioned earlier, CCSMH guidelines. So the recommendations there regarding diagnosis and assessment. So there's a particular tool, which I'll show you in a minute, that was created by the National Institutes of Mental Health, specific criteria for depression and Alzheimer's disease. So that's recommended as a diagnostic tool. And then for detection and assessment, the tool that's highly recommended is called the Cornell scale for depression and dementia. And I'll show you that as well. And the excellent thing about the Cornell scale is that it's based on both interviews with a caregiver, but also the person themselves. This is the Cornell scale, and it includes a comprehensive overview, really, of depressive symptoms, as you can see here. And the very first one is anxiety. You'll see that. And that's not surprising because, especially with older adults, there's a huge overlap between depression and anxiety. Without talking about dementia, but if we talk about older adults with significant depression, many of them have coexisting anxiety. So much so that there's a subcategory of major depressive episode. It's called major depressive episode with anxious distress. So that's a subtype of major depression. But you'll see here a whole variety of mood-related signs. It includes agitation and retardation, which are part of the diagnostic criteria for major depression. Physical complaints, loss of interest. So a lot of these symptoms overlap with the basic symptoms, DSM symptoms for a major depressive episode. Then, then there are cyclic functions or changes in circadian rhythm that are added. And then changes in thinking and ideation, including, of course, suicidal thoughts, poor self-esteem, pessimism, and mood congruent delusions. So I think that adds up to 19 different symptom groups. It's based on the week prior to the interview, and the scorer is asked not to give a score if the symptoms result directly from a physical disability or illness. And then you can get a score at the end. And if it's more than 10, it says there's probably a major depressive episode going on. Score of greater than 18, definite major depressive episode. Now, there's many challenges in diagnosing depression and dementia. The person may have trouble actually recalling, decreased ability to articulate and describe what's going on. Have they lost interest, or are they unable to do the things that they used to do? The sleep and appetite changes overlap. Psychomotor changes overlap. It can be difficult to tease out what's depression and what's actually dementia. So this is the NIMH provisional diagnostic criteria listed here, which looks complicated. But in simplifying it, basically, if you compare the DSM criteria for major depression versus the depression in Alzheimer's disease criteria, so instead of needing 5 symptoms almost every day, you have to have at least 3. So not as many, not every day. And then a couple have been added. Irritability and social isolation or withdrawal have been added. So it's a lower threshold overall for creating a diagnosis of depression in dementia. One thing I wanted to mention was this question of suicide risk in dementia. Obviously, this is always concerning whenever we think about a person who has some degree of depression. So, in this particular paper, they summarized a group of different studies. They note that suicide can occur in Alzheimer's disease even many years after the diagnosis, and that patients who've attempted suicide once are at higher risk of dying from suicide, not a surprise. So they say that Alzheimer's disease is associated with a moderate risk of suicide, and that it's very important for us to be aware of that. And then there was a systematic review by Diehl Schmidt, which actually concluded that dementia as a whole is not a risk factor for completed suicide, meaning that there's not an increased risk compared to the overall population. And Draper, in a systematic review, came to the same conclusion. Nevertheless, there are certain individuals who are definitely at higher risk. So those with depression, when depression is present, obviously, increased risk for those of younger age. Some studies suggest possibly an increased risk for individuals with a subtype called semantic dementia. Possibly an increased risk if the diagnosis was recent, and that makes sense. And then for sure an increased risk if there's a history of self-harm or suicidal behavior in the past. When it comes to actually caring for people and managing or treating individuals with depressive symptoms, so these are the recommendations from the guidelines. So most of these recommendations are non-pharmacological, they're psychosocial interventions, all with evidence to support them. And as you can see, it's a long list. So starting with interdisciplinary approaches of education, structured approaches to assessment, individualized care plans, and personalized meaningful activities. There are a lot of studies suggesting that it can be really helpful to understand what the person enjoys doing, and then increasing those activities as much as possible. But some of those psychosocial interventions include animal therapy, robotic pets, cognitive stimulation therapy, massage and touch, physical exercise, reminiscence therapy, occupational therapy aimed at increasing levels of independence, problem-based therapy, and behavior therapy. So that's a long list. What about antidepressant medications? So whenever we think about, well, any intervention, but particularly medication, we have to think about risks versus benefits. This was an early study by Leketsos of sertraline versus placebo, a randomized trial. And the results look great in this study. This was really encouraging. It really looked like that the sertraline was way better than placebo in this study. Relatively small study, placebo-controlled study. However, meta-analyses, which means combining all of the studies available, have been done, including this one by Ortega. And sadly, the meta-analyses combining the various studies don't really show much of an effect. Very little effect at all, in fact. Now, there have been a few studies. If you look at the top there, two of the studies do show significant benefit, but the others don't. So that's a bit concerning. And so that leads to the recommendations in the guidelines. So the first is to actually recommend against pharmacological treatment for depressive symptoms in dementia where you don't have an actual diagnosis of depression. So for depressive symptoms, we would not recommend antidepressants. But if there is a diagnosis of depression, and if it's persistent and moderate to severe in severity, and it hasn't responded to psychosocial interventions, then antidepressants are recommended for the treatment of a major depression. And this actually parallels recommendations from another set of CCSMH guidelines on depression, which basically say that treat with psychosocial interventions, but But again, highlighting the fact that there's limited evidence to recommend antidepressants, unless the symptoms are really severe and persistent. So let's move to anxiety. So I'm wondering if you could answer this in the chat. If you could just say, why might a person with dementia feel anxious? You could just give one answer in the chat. Think about that. If you, for example, had early dementia, why might you feel anxious? If you put one answer in the chat, that'd be great, or more than one if you have the energy. Yes, I'm looking at some of the answers here. Very good ones. Yes, yes, indeed. Yeah, thank you. Lots of reasons, right? Lots of reasons. Absolutely. Thank you. Very good. And this is an interesting paper. This actually comes from the views of people living with dementia and care partners. Um, and the word cloud here is interesting because on the left are words that are describing agitation, and on the right, experiencing anxiety. And it's kind of interesting. There's sort of a lot of overlap there, isn't that interesting? And so in this paper, they said that, reasons for feeling anxious and frustrated and worried include difficulties with thinking, feeling unsupported, feeling unsafe and fearful, losing independence and a sense of identity. So we know that anxiety is more common in individuals with dementia than those without, and symptoms can occur very frequently. Um, about 5 to 15% of individuals meet criteria for generalized anxiety disorder, and it's associated with worse quality of life, behavior problems, limitations in activities of daily living, nighttime awakenings, poor neuropsychological performance, even after controlling for depression. Again, we know there's a significant with depression. It's also associated with future nursing home placement. So certainly suggests that this is very burdensome for caregivers. So generalized anxiety disorder, that's people who have lots of worries and a whole variety of symptoms that go with that. Um, One of the challenges here is just the overlap of cognitive and anxiety symptoms, so trouble concentrating, fatigue, restlessness, they overlap. In a study of anxiety in people with dementia, those with generalized anxiety disorder were more likely to be male, less severe dementia, caused more worry and anxiety compared to patients without. When it comes to diagnosis and assessment in the guidelines, so for diagnosis, there's no separate instruments. So the group basically recommends using the DSM to diagnose coexisting anxiety disorders in dementia. But there is a very useful detection tool or screening tool called the RAID, which stands for Rating Anxiety in Dementia. So this tool is recommended. By the way, just mentioning that there's a whole group of different anxiety disorders that we have to look out for. This is just to remind you that they include, as well as generalized anxiety disorder, things like social anxiety, specific phobias, panic disorder, agoraphobia, and then substance or medication-induced anxiety disorder. This is the RAID, which has 18 different questions here, and it's certainly a useful tool in rating anxiety in dementia. Covers a lot of the symptoms that we would normally ask about related to anxiety, characterized in groups of worry, apprehension and vigilance, motor tension, as well as autonomic hypersensitivity in people who have significant anxiety. When it comes to the relationship between anxiety and dementia severity, there have been different different studies with different results, so we're not really sure about this. Some would suggest there's less anxious in the later stages of dementia. Other studies haven't found that. Just like depression, anxiety is also a risk factor for dementia. So, a meta-analysis in 2020 from 9 different studies or 8 studies showed that the relative risk was 1.24. That means a 24% increased risk of developing dementia for people who've had history of anxiety earlier on. So that's not as significant a risk as with depression, where it's more than twofold or more than 100% increased risk. But it is still a risk factor. This comes from a paper by Quack et al. And the authors here try to differentiate some of the symptoms between anxiety and depression in people with dementia. I'm not sure I agree with everything here, but it does focus, they do focus on the fact that people with depression are often going to have a much more of a depressive, dark, hopeless, um, um, past-oriented, not future-oriented outlook. Um, but I think one could argue about some of these changes, but I thought it was useful to include. So, what about the recommendations from the guidelines? Overall, there's less research that's been done on anxiety associated with dementia, and I think because of that, the working group were able to come up with somewhat less in the way of recommendations for actual treatment. So for non-pharmacological, they recommended education and training programs for caregivers, cognitive behavior therapy, specifically adapted to people with dementia. And there have been some studies um, supporting this. There's also been some studies focused on music, but music, suggesting some benefits. Um, when it comes to pharmacological approaches, um, citalopram is the best studied antidepressant, so it's recommended for moderate to severe anxiety. And again, the same idea being that start with non-pharmacological approaches, and one would only use an antidepressant for moderate to severe persisting anxiety. This set of guidelines also makes reference to the other set of guidelines, or one of the other set of guidelines that the CCSMH released this year. Those were the anxiety guidelines, and said, "Hey, take a look at those for additional options." So these are the anxiety guidelines, and there are many more recommendations in this set of guidelines because they're not looking at anxiety and dementia. This guideline looks at anxiety in older adults as a whole. So because of that, there are a whole range of non-pharmacological interventions that have been studied and are recommended, as you can see listed here. One important thing to note is that psychotherapies, particularly CBT, have been shown to be very effective in treating older adults, both individual and group CBT. How useful is CBT? Can CBT be in people with dementia? I think that requires further study, but certainly in the early stages of dementia, I think CBT can be very helpful. And then when it comes to antidepressants, the guidelines here include a group of different SSRIs and one SNRI, that's venlafaxine, as treatment for anxiety in older adults. Again, this is not specific to dementia. This is the overall recommendations for anxiety in older adults. So, in conclusion, depression and anxiety occur frequently in people living with dementia, and there is a complex bidirectional relationship with both of these. Useful screening tools include the Cornell scale for depression and dementia and the rating scale, the rating anxiety and dementia scale, the RAID for anxiety. There are revised criteria for a diagnosis of depression and dementia. That's the NIMH criteria, which requires only 3 symptoms instead of 5. And that social isolation and withdrawal and irritability have been added to the conventional DSM criteria. Psychosocial interventions are recommended as a first approach for both depression and anxiety, and there's limited evidence in support of medication, although the symptoms are significant and persistent. Antidepressants are recommended for both depression and anxiety. So thank you very much, and happy to take any questions, comments, thoughts, etc. That's my email if you want to follow up with me at all, and of course the website for CCSMH. You can download any and all of these guidelines from that website.
Thank you very much, Dr. Conn, for that.